Welcome to the interesting and important topic, that is hypersensitivity reactions. So in this particular topic we will see what are the four different types of hypersensitivity reactions, how they occur, and what are the classical examples. So in detail I am going to tell about type 1 hypersensitivity reaction. The type 2, 3, 4 we learn again in the different topics as such. First of all, why we have to study all these hypersensitivity reactions? Remember my friends, we are living in an environment which is containing a lot of substances which are capable of producing immunological reactions. We don't know which patient is allergic to which food, which drug. Patient can be also allergic to dust, pollens, and even microbial agents, chemicals. So we have seen patients suffering from anaphylaxis, immediate type of hypersensitivity reaction due to the penicillin injection. Anti-snake venom, which will inject to save the patient from snake bite, so that itself can cause anaphylaxis and can kill the patient. A lot of drugs, especially the penicillin group of drugs, cephalosporins, are known to cause hypersensitivity reaction, especially it's anaphylactic reactions. So we don't know which patient is allergic to which drug. You should be careful in clinical practice and you should aware about the different types of hypersensitivity reactions. There are four types of hypersensitivity reaction. You should also remember the alternate names for them. Type 1 is also called as immediate type of hypersensitivity reaction. Classical examples are 4A, anaphylaxis, the asthma, allergy, and the atopy. The type 2 is called as antibody mediated. Classical examples are autoimmune hemolytic anemias, good posture syndrome. Other examples we will see. The type 3 is also called as antigen-antibody mediated or immune complex mediated, mainly to say SELI. Other autoimmune disorders like serum sickness, arthritis reactions are also examples of type 3. Type 4 is known as delayed type of hypersensitivity reaction. Classical example is the tuberculosis and tuberculin injection. Then contact dermatitis, multiple sclerosis, and even organ transplant rejections. So let us see one by one. Type 1 is known as immediate type of hypersensitivity reaction. There is a production of IgE antibodies by the plasma cells and release of vasoactive amines and various other chemical mediators, mainly by the mast cell. So the cell that plays the important role in anaphylaxis or type 1 hypersensitivity reaction is the mast cell. As I told, mast cell is nothing but modified basophil or a tissue basophil. Not only mast cell, there will be recruitment of other inflammatory cells as the late phase reaction. We will see pathological lesions like vascular dilatation. The vessels will become very permeable. There will be edema, especially laryngeal edema, which can prove as lethal. Smooth muscle contraction, patient can suffer from bronchospasm because of the variety of chemical mediators that are released by activated mast cells. Huge amount of mucus production that can block the airways, and intense inflammation can destroy the tissues. So it occurs within minutes. That's why it is so called as immediate type of hypersensitivity reaction. A patient may end up with a shock-like condition and it can even prove lethal. So there are two phases of type 1 hypersensitivity reaction. The first phase is the immediate response, which is manifested by massive vasodilatation, vascular leakage, hypovolemic type of shock, smooth muscle contraction and spasm, bronchospasm. Patient will experience severe difficulty in respiration, and there will be a huge amount of glandular secretions that will block the late phase reactions is mainly due to the inflammatory cell infiltrate like eosinophils, basophils, and monocytes that causes massive tissue destruction, and also they causes the mucosal epithelial damage. So try to understand the basic pathogenesis, how this actually the anaphylaxis will occur or the type 1 hypersensitivity reaction will take place. Remember, it's always the antigen to which the person is already synthesized in whom the anaphylaxis will occur. Once the antigen enters into the body, it will be recognized by antigen presenting cells, our macrophages, the modified macrophages. They are the one which will recognize this antigen and submit it to the T lymphocytes. T lymphocytes are get activated and they keep on secreting various interleukins like interleukin 4. Interleukin 4 is the one which will attract the B lymphocytes and they will be converted themselves into the plasma cells. The plasma cells, as you know, they are the one which will secrete the antibodies. So IgE antibodies are secreted by the activated plasma cells. Meanwhile, the activated T helper 2 lymphocytes also secrete interleukin 5 and interleukin 13. These two important cytokines are important for recruitment of more and more eosinophils. So there is recruitment of more and more eosinophils, and plasma cells will attract the mast cells, because mast cells will have IgE surface antibodies over the receptors over their surface. So IgE antibodies, whatever secreted by the plasma cells, will bind to the IgE receptors over the mast cells. So imagine what happens if the mast cell granules will get burst out. So it releases variety of chemical mediators, so called as primary chemical mediators and secondary mediators of inflammation. Not only the mast cells will degranulate and induces a lot of release of mediators, and eosinophils also causes a lot of harmful and adverse effects. So the type 1 hypersensitivity reaction is story of the antigen presenting cells, T helper 2 cells, plasma cells, eosinophils, and most importantly it is the mast cell, which is the important culprit in the immediate hypersensitivity reaction. The damage to the surface epithelial cells, it's mainly due to the secretions, various interleukins and their effects, mainly by the eosinophils and mast cell, the chemical mediators that are released by eosinophils and the mast cells. So remember, once the mast cell is get degranulated, it releases variety of cytokines. There will be release of massive amount of histamine. Histamine is the one which is potent vasodilator. It increases the vascular permeability. There will be also release of proteases. More and more eosinophils will be recruited by mast cells. So mast cells will secrete eosinophil chemotactic factor and neutrophil chemotactic factor that further causes tissue damage in the late phase. The breakdown of the mast cell membrane results in the liberation of the arachidonic acid metabolites. There will be release of leukotrienes B4, C4 and D4. They are the one which causes bronchospasm. There will be also release of prostaglandins which causes vasodilatation. Directly the signals, antigen antibody complex combination will send a signal to the nuclear factor Kb, which in turn causes release of other variety of cytokines. So remember the role of mast cells in type 1 hypersensitivity reaction. What are mast cells? They are nothing but the basophils. They are bone marrow derived cells widely distributed in different tissues. They will have a peculiar granules which are cytoplasm bound granules, and they take a very special stain, so called as metachromatic dye. Toluidine blue is the special stain required for demonstration of the mast cells. They contain their weapons, histamines, which is important vasodilator. Variety of enzymes will be liberated once the mast cells will degranulate. It liberates proteases, acid hydrolases. Other proteoglycans like heparin and chondroitin sulfate will be get liberated. Anaphylotoxins C3A and C5A also will be get liberated as a part of activation of these mast cells. So they have been classified, the mast cell granules have been classified and their chemical mediators have been classified as primary mediators and secondary mediators. Primary mediators mainly consist of histamine. Remember the role of histamine, which is commonly asked in MCQs, that it is a potent vasodilator. It also causes smooth muscle contraction. It increases the vascular permeability. Variety of enzymes, proteases like chymase and tryptase, they are the one which will cause massive tissue damage in the late phase. Even proteoglycans will be get secreted. The secondary mediators of allergy that are secreted by mast cells are mainly the lipid mediators, that is leukotrienes. Leukotriene C4 and D4, and even prostaglandins will be get secreted. Other cytokines that are secreted are PAF, platelet activating factor, the tumor necrosis factor, interleukin 4, 5 and 6. Eotoxin is the one which will attract the more and more eosinophils. That also will be secreted by the mast cells. Interleukin 4 is the mast cell regulator which is released by the T lymphocytes, activated T lymphocytes. So try to remember the important aspects in the type 1 hypersensitivity reactions, that it is the antigen presenting cells, nothing but dendritic cells. They are the one which will capture the antigen. T lymphocytes, they will differentiate into T helper 2 lymphocytes. and they are the one which will liberate interleukin 4. Interleukin 4 in turn activates the B lymphocytes, and they convert the B lymphocytes into plasma cells, which will liberate the immunoglobulin E, IgE. IgE is the one which will attract the mast cells, because mast cells and basophil vacuum expresses the IgE receptors over their surface. Interleukin 5 and interleukin 13 are the one again liberated by the activated T lymphocytes. Interleukin 5 is very important for activation of the eosinophils. Interleukin 13 activates the both epithelial cells as well as the eosinophils, and it produces huge amount of mucus. This mucus can form a mucus plugs, and that can block the airways. The classical example is the asthma. Asthmatic patients will have the classical family history of asthma will be there. So asthma is more of genetically susceptible. So patients will have a family history that we have to ask the patient that any person in the family is having asthma. So it's said to run in the families. Remember the four A's for the type 1 hypersensitivity reaction: anaphylaxis, mainly after the penicillin injections. Allergies could be due to the food allergy, drug allergy, allergic rhinitis, allergic conjunctivitis. Asthma, that is bronchial asthma, is a prototypical example of type 1 hypersensitivity reaction. Then atopic fever, nothing but hay fever. Atopic fever, it is again genetically determined. Here again immediate hypersensitivity reaction occurs to wide variety of inhaled or ingested allergens. So these patients, the patients who are atopic, they will have always peripheral eosinophilia. If at all you estimate their serum IgE levels, it will be always very high. The AEC levels, absolute eosinophil count levels, will be very high in these patients. The prototypical example for type 1 is again systemic anaphylaxis, which will manifest with a vascular shock, widespread edema, especially there is laryngeal edema, which is very grave as such. Patient can also manifest with the vomiting and diarrhea. Sometimes even they die if the immediate resuscitation is not done. So variety of drugs, especially it's a penicillin group of drugs, cephalosporins, are known to cause anaphylaxis, but even variety of other drugs and even anti-snake venoms are known to cause these anaphylaxis. Hormonal products, the artificially synthesized hormones, enzymes, antisera, all those things are capable of causing the anaphylaxis. But remember, anaphylaxis will not occur on the first episode, it is the second episode which can kill the patient. So previous history of allergy is very, very important. You have to ask before injecting these kind of drugs. So if you see the type 1 hypersensitive reaction, you can tell is immunity is good or bad, is it useful or harmful. Remember, immunity is something like a double-edged sword. It cuts on the both sides. It is useful and it is equally harmful when it is in excess. So hypersensitive reaction are all due to the exaggerated immune response, which can prove sometimes lethal. That's about type 1 hypersensitive reaction. Let us see the type 2, that is nothing but antibody mediated hypersensitivity reaction. So the mechanism that are involved are three different mechanisms. It is all antibodies that are directed against the antigen present on the cell surface or extracellular substances. They explain the three different mechanisms: opsonization, complement and FC receptor mediated phagocytosis, complement and FC receptor mediated inflammation, and antibody mediated cellular dysfunction. I will not go into detail about these all mechanisms. The examples of type 2 hypersensitivity reactions, the opsonization mediated are mainly its autoimmune hemolytic anemias. All types of these autoimmune hemolytic anemias, they come under type 2 hypersensitivity reactions. Then various transfusion reactions and even erythroblastosis fetalis is classical example of type 2 hypersensitivity reaction, that is antibody mediated. Complement mediated are vasculitis, good posture syndrome, acute renal failure, and various types of glomerulonephritis. All these things we will learn in detail in the systemic pathology. The antibody mediated again is the myasthenia gravis, Graves' disease, insulin resistant diabetes mellitus, pernicious anemias, and pemphigus vulgaris. In short, you can make a mnemonic like MDPT, that is to remember the various example for type 2 hypersensitivity reaction. M stands for myasthenia gravis. D, variety of drug reactions, mainly it's a hemolysis following the penicillin. pemphigus vulgaris, then transfusion reactions, then erythroblastosis fetalis, and variety of autoimmune hemolytic anemias. So these are the example of type 2 hypersensitivity reactions. Type 3 is also known as immune complex mediated hypersensitivity reaction. Antigen antibody complexes, whichever they are formed, they get circulated in the various blood circulation but gets deposited at the site of production, and these immune complexes very classically get deposited in the vessel wall. Of course, the formation of antigen antibody complex formation is a normal phenomena for removal of the antigen, but if these antigen antibody complexes are not removed from the body, then only person will develop a immune complex mediated hypersensitivity reaction. So two types, generalized and localized. So you can remember by a mnemonic the example for type 3 hypersensitivity reaction, that is immune complex mediated SP-PARS, systemic lupus erythematosus, that is SLE, PAN polyarthritis nodosa, post-streptococcal glomerulonephritis, acute glomerulonephritis, reactive arthritis, arthros reaction, and the serum sickness. So these are the example of the type 3 hypersensitivity reaction. So antigen antibody complex formation is normal phenomena. As such, whenever the antigen enters into the body, there is a formation of corresponding antibody. So the phase 1, that is immune complex formation, is the normal mechanism. But once there is an immune complex formation, once the function is over, that will be easily removed from the phagocytic cells. They will not be get deposited. Whereas in a person who is genetically predisposed for these autoimmune disorders, there is a deposition of the immune complexes, especially in the vessel wall. And once the immune complexes are get deposited in the vessel wall, they elicit intense inflammatory reaction around the immune complexes that will destroy the vessel wall as such. The vessel will suffer from a kind of necrosis, what we call it as fibrinoid necrosis. So we see the details about this in a chapter of SLE. Various factors will influence this antigen antibody complex deposition. The size of immune complexes is very important. Large complexes are easily recognized, and that's why they are rapidly removed and they are relatively harmless. Whereas smaller are the ones which are more dangerous. They circulate for a long time in the blood circulation, and they usually escape the recognition, and they are the one which will get deposited, and they are the one which will cause more harmful effects. Functional status of a mononuclear phagocytic system is also important. Any intrinsic dysfunction in the phagocytic system, it causes the persistence of the immune complexes for a long time in a circulation, and that can become more dangerous. The variety of other factors that also influence the antigen antibody complexes are the charge of the immune complex, the affinity, the structure. Variety of hemodynamic factors will influence the removal of these antigen antibody complexes from the vessel wall. So which vessels? The vessels of the glomeruli are the ones which are commonly get affected. So when you use the word glomeruli, it is a tuft of capillaries. So kidneys are the ones which are commonly get affected with these immune complex disorders. Immune complexes, because the kidney is the main filtering organ, kidney is the one which is get affected. But immune complexes can be also get deposited over the joints, in the skin, over the heart, over the various serosal surface, and even in the lung surface. That's about type 3. We will see the details about various autoimmune disorders in the next topic, that is autoimmune disorders. Coming to the last category, that is cell mediated, which is type 4, or we also call it as delayed type of hypersensitivity reaction. It could be either CD4 T cell mediated, or it could be CD8 T lymphocyte mediated. Classical example is the tuberculosis, but other example also you should remember. The other granulomatous inflammatory conditions are again type 4 hypersensitivity reactions. Tuberculin skin test, that also again is a very classical prototypical example of type 4 hypersensitivity reaction. The transplant rejection, organ transplant rejection, also comes under type 4 hypersensitivity reaction. Contact dermatitis is again example. So tuberculin injection, where very small quantity of tuberculin will be injected into the skin in the volar aspect of a arm. It is mainly to identify the susceptible person in a population who are prone for tuberculosis. Remember, it's a screening test for tuberculosis, not the diagnostic of tuberculosis. Usually it is performed in a family members of a patient with an open case of tuberculosis. if one person is suffering from tuberculosis whose sputum is positive, and you have to screen the other members with a tuberculin injection. So to know family members who can get affected with tuberculosis and who are already exposed and who are immune, you can categorize the patients based on the severity of a reaction. Mild reaction indicates that patients are immune to the tuberculosis. If there is no reaction at all, that indicates that he could be a immunocompromised patient. If there is a severe induration and erythema, they are the cases of hypersensitivity reaction. So the person who are immune, you need not give any tubercular prophylaxis. In a person who will have no reaction at all, such a person you have to further investigate whether they are the cases of immunosuppression like HIV and AIDS. The person who are again show anaphylactic reaction or a severe exaggerated reaction where you will see erythema and induration more than 1 centimeters, they are the one who needs the prophylactic treatment with the antitubercular drugs. So to summarize the hypersensitivity reactions, type 1, 2, 3, all of these 3 types are antibody mediated, whereas type 4 is the cell mediated. Remember the type 1, the classical example 4A's, asthma, allergy, the anaphylaxis and the atopy. It's all the story of mast cells and the eosinophils. Atopy is very classical example again where there is exaggerated tendency to mount the IgE response. In type 1 hypersensitivity reaction, the IgE serum levels should be very high. Type 2 are the one which is again antibody mediated. Again remember the examples, MDPT. Type 3 is the one which is due to the mainly antigen antibody complex mediated. So we'll see in detail about these autoimmune reactions in the next topic. Type 4 is the cell mediated, classical example is the tuberculosis. So let us have a look on the type 3, that is antibody mediated, that is autoimmune reactions in detail in the next topic. Thank you.